Welcome, everybody. My name is Stephen Ferrara, and I'm the Executive Director of the Nurse Practitioner Association, New York State. Before we get started with tonight's webinar, I just wanted to go over some housekeeping items. So we'll get this out of the way. Everyone who's joining us is muted, so we won't hear any background noise, and your cameras are actually turned off as well. This webinar is being recorded and it will be available at another time, and we'll email everyone once the recording has concluded and we have it uploaded. There are no contact hours for this webinar. We intentionally we wanted to award some contact hours, but because we wanted to get the content up and have this webinar, it was important to have the webinar before we got the contact hours approved. So there are no contact hours, and we are live streaming on to Facebook right now as well. There is a Q&A button that you can ask the panelists questions. We ask that you use that Q&A button for any questions you may have. We will not be monitoring the chat feature for any questions, so please use the Q&A. So our title tonight is Structural Racism is a Public Health Crisis. What can advanced practice nurses do? And this is being held in conjunction with the S.D.F Group, the Greater New York City Black Nurses Association, and the National Association of Hispanic Nurses, New York chapter. Joining us tonight are three panelists. Dr. Sheldon Fields is the founder and CEO of the S.D.F Group. Dr. Julius Johnson is the president of the New York City Black Nurses Association. And Dr. Michele Crespo-Fierro is the president of the National Association of Hispanic Nurses, New York chapter. We have four objectives for tonight. We're going to define structural racism and identify underlying contributing factors to it. We're going to discuss the social determinants of health and how they potentially contribute to health disparities. Identify strategies that are trauma-informed and culturally congruent to integrate into clinical care encounters, and evaluate administrative strategies that address issues of structural racism for implementation in the clinic setting. This is an action-based webinar. We hope that you will take the information learned tonight and directly apply it to your clinical practice as soon as possible. And without further ado, I'm going to hand it on over to Dr. Sheldon Fields.
All right. Good evening, everyone, and thank you, Stephen. I appreciate the opportunity and the platform that the New York State Nurse Practitioner Association has afforded us this evening. My task is to introduce the topic, and I'm going to do so by talking and doing an overview on structural racism and the social determinants of health. We're going to define what structural racism is for you all, and again, talk about the specifics related to the social determinants of health. But before I even go any further, I really want to lay some foundation. And part of the reason why we're here tonight is because of all of the social unrest related to the issues of racism in our country. So I particularly like this slide that reads, "Black is and Black ain't." Blackness is simultaneously a category, a group, a culture, a community, and an identity that varies between individuals. Blackness involves an awareness of one's history, a shared experience, and a comfort in one's current skin with an idealized hope for the future. And I start there because I want to be really clear about two things before we go any further. Before the revelation of a lot of people that racism was real, anybody Black in America knew that, and we could have told you. And in fact, we have been trying to tell most people. We also know that Black Lives Matter is more than just a catchphrase, because we've known that our Black lives have mattered for quite some time. That being said, what is partly all of this about? The current social upheaval and protests that are deeply painful are rooted in a long history of discrimination and oppression against Black people that has most recently been manifested in the multiple killings of Black people at the hands of law enforcement officers. The killings, which date back many years, is the reason why the Black Lives Matter movement even came about. This phrase, Black Lives Matter, has now taken on a life of its own, painted on streets across America. And that is for a specific reason. The most current incidences of Breonna Taylor, George Floyd, and most recently, Rayshard Brooks in Atlanta, are names that have been added to a growing list of those killed most recently. But there's been many, many others, some that we've heard of and some that we have not. So I want to call a few people's names in the pictures that you see on the right side of this slide. Tamir Rice, Trayvon Martin, Eric Gardner, Philando Castile, Sandra Bland, Oscar Grant, Kayla Moore. We call their names. They are now with our ancestors. We call their names. The interesting part about what you're seeing has to do with the historic issues related to historical trauma for the Black community that is rooted in America in a very long history of slavery, followed by many years of segregation, followed that by Jim Crow, and the current issues related to mass incarceration. Historical trauma, which is trauma upon trauma, is not unique to the Black community. We've also seen it in other cultural groups, the Jews with the Holocaust, the Japanese with internment, the Native Americans, genocide and relocation. But that is why we're here tonight. So that being the case, let's move forward with discussing the issue and defining what exactly is structural racism. And it is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial inequity. And we see those racial inequities all within our society. It defines the very dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. Structural racism is really a part and a feature of our social, economic, and political systems. It permeates all of the various facets of our society. Related to structural racism is institutional racism, which refers to policies and practices within and across institutions that intentionally or not produce outcomes that chronically favor or put one racial group at a disadvantage. If you look at the historical injustices in the criminal justice system, African Americans are 13% of the population, and in some states, they are 30 to 50% of the incarcerated population. Historically, poor school districts, which are often minority or where brown and Black people exist, based on how we fund our school systems from the tax base and the history of redlining, those are under-resourced. Employment and racial discrimination in employment. 40+ million Americans are now unemployed due to the COVID-19 pandemic. But I assure you that there's a disproportionate number of African Americans and Blacks that are unemployed related to their white counterparts. That is institutional racism. This is a really good video that I want you to watch at a different time. I'm not going to play it for you, but it talks about institutional racism via a Michael Jackson song. We'll send you this link so that you all can view this at a later date. So now, how does this get us to the issue of healthcare disparities? Well, healthcare disparities, defined by the World Health Organization, are differences in health outcomes that are closely linked with socioeconomic and environmental disadvantages, often driven by social conditions in which individuals live, learn, work, I often add die, and play. Literally, you've heard the phrase, when white folks catch a cold, black folks get pneumonia. COVID-19 hit all of us in America, followed by the advent of our current racial and social upheaval. And this has been a pandemic within a pandemic for Black America. There are many differences in social determinants of health, and those conditions that place people at risk for adverse health outcomes. One other thing I really want to bring up, and I'll bring it up here, is this issue of health equity, because it's related to healthcare disparities. And I want to talk about this before I move on to talk about the social determinants of health. Health equity, and I'm going to use a definition by Dr. Kamara Jones, a former president of the American Public Health Association. Dr. Jones defines health equity as the assurance of conditions for optimal health for all people. And she espouses three underlying principles that, if we practice, would get us closer to health equity. The first condition is believing in the fact that we should provide resources according to need. The second is that valuing all individuals and populations equally. And the last is recognizing and rectifying historical injustices, such as those that I have already spoken about. Now, why am I going to talk about COVID-19? Because COVID-19 did not cause all of the issues related to health that we see in Black America. COVID-19 laid bare the issues that were already there. Again, 13% of the population, but they accounted for 30% of COVID-19 cases across many, many states. And Blacks had a higher fatality rate of about 2.4% times greater than their white colleagues. So what were some of the differences in infection death rates, and why did we see that? Well, one was an overrepresentation of Blacks that made up the quote unquote essential workforce. Black America had to go to work. They didn't have the privilege and the opportunity to stay home and socially distance. Population density in highly urbanized areas where large Black populations exist, housing and transportation. The historical trauma and the mistrust of our medical system, and the structural racism that I talked about, and an ongoing issue of cultural competence within our medical system to take care of the issues of Black America. Lower health insurance rates and lack of Medicaid expansion, especially in southern states where large, again, Black populations exist. Income inequality. The average white family has 10 times the economic wealth of the average Black family. Again, I never made my point about employment discrimination, political gerrymandering, and an underlying issue with higher prevalence of some chronic health conditions. This is just simply a slide that talks about the maldistribution of COVID-19 in several states related to race. So I'm not going to spend a lot of time on this particular slide, but I want to talk about this one. because across all age distributions, in terms of chronic healthcare conditions, Blacks suffer disproportionately from high blood pressure, diabetes, and stroke. Just as an example of some of the healthcare disparities that we know already exist that have been exacerbated when it came to the COVID-19 pandemic. The landmark study of the Institute of Medicine, now the National Academies of Medicine, study Unequal Treatment, Confronting Racism and Ethnic Disparities in Healthcare, even proved that minorities received a lower quality of care than whites, even when everything was equal, even when they had the same economic ability, the same amount of money, the same, actually even the same health insurance or the ability to pay. Somehow, minority populations still received a lower quality of care. So what causes these healthcare disparities? Part of it is the healthcare system, organization and operation, how our healthcare system is actually set up. Patients' attitudes and behaviors, again, back to the issue of historical mistrust, that is rightly so when you think about the issues that Black America dealt with the Tuskegee experiment in the issue of Henrietta Lacks. Healthcare provider bias. Everyone has bias. I don't care who you are in the healthcare system. Everyone has bias and prejudices. And sometimes it's at a conscious level and sometimes it is not. But that's what feeds into stereotypes and all of the isms that we see. The Kaiser Family Foundation, I really like this slide that talks about the social determinants of health because it puts it into several different categories. So talk about the economic stability, which is all the things I talked about previously about employment and income. The actual neighborhoods where people live. Nothing more in America determines your ultimate health status more than your zip code. And that's really astounding when you think about it. Because that talks about the type of housing you live in, transportation that you take, whether or not you feel safe in your neighborhood, whether or not you're able to go outside and exercise because you have a park to do so, or playgrounds, whether or not it's walkable. Education and access to education has not been equal in this country, even though there literally had to be a Supreme Court case to rule on equal access to education. The way in which we fund education makes it still unequitable. Food and food deserts. In some areas, there are not grocery stores. People do not have the same access to fresh food. Community and social context about the support systems, the community engagements, the levels of stress in your community. And of course, we already talked about the healthcare system biases, all feed into the disproportionate health outcomes, the differences in mortality and morbidity, the lower life expectancy in the African-American community compared to whites, and our lower healthcare status and qualities of health. This is the slide I was alluding to about wealth inequality. The racial wealth inequality, which is rampant in America. Look at the distribution in wealth. When you compare the average white family to the average African-American family and even the Latino population, the numbers are just astounding. And you can see that on the graph for yourself. The era of slavery was when white Americans determined that Black Americans needed only the bare necessities, not enough to keep them optimally safe and healthy. It set in motion Black people's diminished access to healthy foods, safe working conditions, medical treatment, and a host of other social inequities that still to this day continue to negatively impact the health of Black America. And that is a quote by Dr. Sabrina Strings. And this alludes to some of those structural factors that are driving disparities that I talked about earlier. Because these things are not necessarily intrinsic to the characteristic of Black communities or to the individual themselves, but really it is above them in things in which they do not have the power to control. But let's talk about some potential general solutions before I end my presentation and turn it over to my two colleagues. So generally speaking, what do we need to do about some of these inequities and where we find ourselves today? So we need to support American First activities and initiatives, public works projects to put people back to work, the canceling of rent, extending unemployment insurance, enhancing the Affordable Care Act, and opening it up again so that people can enroll and actually still get health insurance. We need to do something about student loans, which Black students come out disproportionately saddled with loans. And dare I say, we probably need to cancel student loans. We need to extend SNAP benefits, that's food stamps, what we think about as traditional food stamps. Death benefits. We have had some over 200,000 people honing in have died from COVID. And there are not enough benefits to people having struggling to bury their loved ones. And there are some other policies that we can think about that directly address structural racism. We need to demand and ensure that race-based data is collected to monitor the progress of public health issues in all states, not only COVID-19, but even the disparate health conditions. We need to have good data. We need to demand fairness for all essential workers, who again are disproportionately people of color. Free PPE, a $15 minimum wage, benefits for part-time work. We need to reform our public school funding models. We need to ensure that policy reform initiatives include direct input from Black communities and stakeholders. We've seen a lot of talk about defunding police and all of these issues. You cannot do any of this in a meaningful way if you don't include the stakeholders in a Black community who have been disproportionately impacted. And last but not least, we need to finally establish a federal commission to seriously look into, consider, and study the issue of reparations for Black America. I'm going to end with some of my favorite quotes. To be a Negro in this country and to be relatively conscious is to be in a rage almost all of the time, by James Baldwin. I've learned what people will forget what you said, people will forget what you did, but people will never forget how you made them feel, by Dr. Maya Angelou. The last one I'm going to share is the bottom one. In the end, we will remember not the words of our enemies, but the silence of our friends. And that was Martin Luther King Jr. This is not time for any of us to be silent about these issues. And I'm so glad that we're here, that we can open up a dialogue specifically about what we all can do as advanced practice nurses. I've been a nurse for almost 30 years. I've been a family nurse practitioner since 1995. And a lot of these issues we've seen before. This is my contact information. I live in public. I'm more than happy to always have a follow-up conversation with anyone. I'm going to stop sharing my screen, and I'm going to turn over things to my colleague, Dr. Crespo-Fierro.
Well, thank you, Dr. Fields. A wonderful presentation as always. And I want to thank the Nurse Practitioner Association of New York for this invitation to speak with all of you. And I also want to express my gratitude for the partnership that seems to be developing between myself and Dr. Johnson and Dr. Fields. It has, I am very grateful to be on this journey with the both of you. So I'm going to open up my slides here. And I'm going to have us look at what is it that can be done to really build a practice that can address issues of structural racism, and how can nurse practitioners in their direct patient encounters, but also the practice setting, be agents of change. So the objectives for my portion of this presentation are to identify strategies that are trauma-informed and culturally congruent to integrate into clinical care encounters, and then also to evaluate administrative strategies that address issues of structural racism for implementation in the clinic setting. So, there will be a little overlap, but definitely a different take. So I wholeheartedly agree that we all have some type of bias. It is the way that our brains organize information, but we need to be very aware of what it is that our brains are doing. And if our brains are going down a path that is not appropriate, we need to have that awareness and stop ourselves. So we need to acknowledge the privileges that we all have. And depending on which boxes you'll tick for your identity, there can be any of these. So you can experience the privilege of being white, the privilege of being male, the privilege of being heteronormative, the privilege of being cisgender, the privilege of the economic status that you enjoy, your educational background, Judeo-Christian, and I could go on and on. But these are our the usual ones that we potentially can benefit from. And we have to acknowledge that privilege is a lens through which we see not only our own experiences, but the experiences of those who are different from us. So this sometimes is the impediment for us to develop empathy for the people that we engage with in any part of our lives, whether it be our work lives, our personal lives. It may impact or get in the way of our developing empathy for others. And then it distorts us and determines how we classify what we observe. So we need to learn how to differentiate between what is our lived experience and our training and our education and what other people's experiences are and what their education and their experiences have brought them. So we can potentially, if we don't check this implicit bias, we can make decisions and clinical decisions based on assumptions that we make with incomplete information, because potentially we haven't taken the time to ask someone about what their experiences are. So I share with you here the implicit project Implicit at Harvard University. And this is an interesting way, it's a series of tests that you can discover what your own implicit biases are. And there are many different categories that you can choose from. This is one that I use in my work with my students. And even my colleagues have used it, and it usually turns up some very interesting biases that we may or may not realize that we actually have. So we must acknowledge the impact of racism. It is not something that should ever have been swept under the rug. It needs to be held out into the light of day, because racism absolutely does impact everyone's experience. So, and I also very heavily quote Dr. Kamara Jones. She is a phenomenal woman with incredible insight. And I always learn, whenever I re-listen to her her speaking, I relearn things and have new nuggets of knowledge that I take with me. But she describes racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, and which is that what we call race. And this system unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. That is, number 3 is an incredibly profound statement, because we all lose because of racism. We see these advantages and disadvantages play out in the social determinants of health, and the existence of racism in itself is a generational traumatic experience. What we are gaining knowledge that is telling us that the experiences of people in the past is passed down in their genes, and this is an absolute tragedy, because it's putting people at risk for conditions from the get-go, and that is something that just should not be tolerated. I'm using the healthypeople.gov listing of the social determinants of health, but as you may notice, it is very similar to what was shared by Dr. Fields through the Kaiser Health Foundation. And so we have economic stability, education, health and healthcare, social and community context, neighborhood and the built environment. And what I would like to propose is that it is our responsibility as healthcare providers to be able to access this information and include it in our assessments of our clients, our patients, because it's this information that really explains what those disparities are, not what that blood pressure monitor said, not what that lab work said. These social determinants of health are really what is going to tell us what is and is not going to be successful in our work with them. But no matter what, we have to build trust, and we have to demonstrate that we are trustworthy. We, even no matter what our identities are, we represent the healthcare system, and the healthcare system has done a tremendous disservice to communities of color, and especially the Black community. And we need to acknowledge that. Yes, we have the stories of the out of Tuskegee. We have what we know about Henrietta Lacks. We have many stories, and we can attribute those to many minority groups, and we need to acknowledge all of them. So what does that mean? How do we build trust and demonstrate our trustworthiness? So first of all, we need to know and then practice the value traits of a provider for the client. So we need to take the time to find out from our clients, what do they want? What are the value traits that they want from a provider that's going to encourage them to come back for a follow-up visit? We have to know what those are, and we have to learn those traits, and we have to demonstrate them. Not just once, not just the first intake visit, but every visit, we need to demonstrate that we are trustworthy. We will make mistakes. We are learning this. We perhaps may forget parts of people's culture or something that they tell us, but we shouldn't be embarrassed to write something down. We shouldn't be embarrassed to check our notes to remind us that Mrs. Jones prefers a hug when she comes in for her visit. So you give her that hug, because that is what she is coming in for, as well as your medical knowledge, your nursing knowledge. We need to practice with the ethical principles of our profession in mind. So we need to respect their autonomy. So that may mean that they may not follow our plan of care. And if we're calling it our plan of care, then rest assured, we did not include them in the plan, and it's not their plan, and they should absolutely not follow it. We need to practice with beneficence and non-maleficence. So we need to know who we are caring for in order to, and ask them what they consider harmful and what they consider good for them. We need to be truthful, we need to be faithful to them, and we need to practice with justice in mind. And while every little one of our actions will bring individual justice, but if we're doing this all together, then we can bring about systemic justice, and we can be part of that. We must have humility in all of our interactions. We are learners, we are human, and there is always something that we will benefit from in all of our interactions with our patients and clients. And mentoring is key. We need to seek mentoring on how to do this, because this, for many of us, was not something that we were taught in our nursing programs and our entry to practice programs, as we move through in our higher degrees and nurse practitioner programs. This is not always something that is taught. So we need to seek out mentors who will help us to develop this skill set. And then we also need to take on the role of mentoring those who come after us. We need to pay it forward. We should also recognize the value of culture and religion to care. So culture and religion both influence the practices and beliefs that impact health and wellness. And those are dietary practices, different activities, celebrations, expressions of spirituality and religion, and our perceptions and desires in our births, our lives, and our deaths. So it is the responsibility of the provider to get that information. And sometimes the best place to start is to actually ask the client themselves. We also need to acknowledge that people have different levels of acculturation. So do not make the assumption that because you once cared for an elderly Jamaican man does not mean that this young Jamaican woman in front of you experiences and expresses her culture in exactly the same way. She may be born in the United States, so she may be acculturated to the U.S. culture. So that's something for that needs to be considered. So AACRNs can make this part of their intake. So if they add a few questions into their assessment forms and actually review them and ask questions for further clarification, this is a very simple way that you can start to build that knowledge for you and the clients that you care for. So I will acknowledge that I follow the practices of Madeline Leininger, in the sense that I do look at transcultural nursing is very important, and the culture care decisions and actions have been applied by Eberly here, who is a nurse practitioner, and she defines culturally congruent care as the use of culturally based healthcare and health knowledge in sensitive, creative, and meaningful ways for beneficial and meaningful health and well-being. So there are ways that you can respect people's cultures and actually use with them and their practices and incorporate them into the plan of care that you design with them. So they will tell you what those are, and some really meaningful ones particularly are the family and the role of family in wellness, the role of spirituality in calming someone, in giving that person a meaning in their life. And as a nurse practitioner, you can take those and use those as you develop that plan of care with them. Sometimes there are some cultural care practices that can be harmful. And, you know, we look at those activities that need to be relooked at. And we need to be sensitive. We can't tell people, you have to stop doing these things. Because if this is part of their culture, part of their religion, part of their lives, they're not going to stop. It's part of what gives them meaning. But if we take the time to sit with them and talk about what are equivalent activities maybe that they can do, what are ways that they can be modified, then we can develop that plan, and really they will be engaged and they will be directing that plan and they will be following through because it's what they want to do, not what we want them to do. So we also want to talk about trauma-informed care. What has been happening is essentially organized trauma. And it has been happening, again, across generations. But we need to look at our practices and are we practicing in a trauma-informed way? Ideally, this is practiced with everyone because we do not know people's trauma. People may be, the trauma may be buried, the trauma may be well hidden, and we may not know about it, and oftentimes can't find out about it until we've developed trust. And it will take more time for people to trust us, particularly if we are new to them or they're new to us. So we need to practice trauma-informed care. So it realizes the widespread impact of trauma and understands that there are paths for recovery. There are signs and symptoms of trauma in patients, families, and staff. We have to acknowledge that we also have our own trauma. It integrates that knowledge into policies, procedures, and practices, and actively avoids re-traumatization. You know, when you look at the potential for re-traumatization, every time we make someone who has been disrespected, who has potentially suffered the impact of discrimination as they've accessed healthcare. And if we ask them to tell us that story yet again and again and again, we're not practicing trauma-informed care. We are re-traumatizing them. And we need to find ways that avoid that re-traumatization. One way that we often re-traumatize is when we, in education, when we send in students, practitioner students, to do the history and to ask those questions again and again. We're re-traumatizing them. So we have to rethink that. There has to be a better way to get the information and help the students to learn how to do those assessments without re-traumatizing the patients. The administrative milieu needs to encourage full integration. So what does this mean? It means that it's got to be more than lip service. We have to not just talk the talk, but walk the walk. It needs to be embedded into the mission and vision of the practice, and any orientation programming needs to be, it needs to include every single employee of the practice. Everyone needs to be practicing trauma-informed care. And that does include the custodian. That includes the person who greets them at the door. Everyone needs to practice that. And we have to have resources available. If we're going to ask questions about trauma because we need to get that information to provide the care, then we need to be ready with those resources. We cannot ask these questions just because we're interested in knowing. We need to be ready to care for them. The principles of trauma-informed care: safety, utmost safety, both physical and psychological for clients and employees. Again, that trustworthiness and that transparency. All decisions must be transparent in the care that's delivered to build and maintain trust. Peer support, having people working with you who perhaps understand and have had those experiences, and providing opportunities for there to be support amongst peers is very important to the service delivery. Collaboration must occur, and power differences must be equalized, so that way there's shared decision making throughout the practice. So it's not just within that individual exam room or meeting space, it's actually throughout the whole organization. All strengths are to be validated to build resilience, and that's the overriding outcome that we're seeking, is resilience in all. Belief in the ability to heal one's past trauma. And then that is empowerment. And that in humility and responsiveness, that biases, stereotypes, and all historical trauma are recognized and addressed. So how can you integrate this trauma-informed care and this awareness of social determinants of health into the practice setting? So the first place to start is those intake forms. If you ask questions about potential transportation concerns, that may help you strategize to avoid someone missing an appointment because they happen to live in an area that has irregular transportation. The schedules are not well followed. If we understand and ask questions about the housing, where do they live, who lives in the home, this will help us to make plans accordingly. What is the access to housing? Maybe this person does not have access to housing at all. What is the quality of the housing? But as we've seen in COVID-19, understanding that many people of color live in multi-generational homes, and they're caring for elder parents, aunts, and uncles, that the family is not the traditional nuclear family of parents and children, that we actually include other people who are related to us by blood, by marriage, or just by life circumstance. They have become our family. So understanding that helps to plan accordingly. Those questions weren't asked when we were telling people to stay home and not leave their homes during COVID-19, the stay-at-home orders. We need to know those neighborhood concerns. Again, as Dr. Fields has mentioned, if there's not a sense of safety, then that beautiful park that's there that someone could potentially go for walks in every afternoon, it's not going to happen. So we need to know those things. What kind of scheduling does someone have? Do they work? What are their work schedules? Do they also go to school, or do they have children in school that they're picking up? This is important for us when we're trying to plan scheduling. Perhaps the clinic is not open and the office is not open late enough to accommodate someone who works a 12-hour schedule. We need to consider that if we want to engage people in care. We need to develop partnerships with services, so pharmacy and laboratories. So that way, if we are, if anything's being ordered, that whole process is facilitated, and it's not another trip to be scheduled on another day. The easing that scheduling will be helpful in delivering care. Educational materials and health literacy. We need educational materials that are culturally appropriate. If there are pictures of individuals, that those pictures look like the clients that we are handing these materials to. If there is a language, that it's in the language that they understand, and is written again at a level of literacy that that someone will be able to understand the information that's being provided to them. We need to include social supports in the care planning at all times, because this is if this is part of someone's culture, then this is how we support them to regain wellness. And we need to also assist people with accessing food programs and other programs. And that's a huge part of health literacy. You know, navigating, knowing how to fill out these forms is difficult. And even for most of us, those of us who perhaps have degrees, these forms are difficult, and that is purposeful. Purposefully, some of these forms are very difficult. So we need to make sure that people are supported if we are asking them to navigate these programs. And with that, I'm going to close. Those are just some of the strategies that you can potentially use. But there are more that you can determine that work best for yourself. So I wish you luck as you, and actually I hate using the word luck. I wish you well. Luck leaves things to chance, and we can't leave any of this to chance anymore. We have to do the work and make it happen. But as you build your trauma-informed practices. So thank you. And I think at this time, I will turn everything over to.
Thank you, Dr. Crespo. And good evening, everybody. My name is Dr. Julius Johnson. I am currently the director of the Family Nurse Practitioner Program at Long Island University, Brooklyn. I also have my own company, Premium Health Depot, where I specialize in home-based primary care and transitional care, which I've had the pleasure of specializing in for over 10 years now. And I also do medical marijuana certification. I'm the president of the Greater New York City Black Nursing Association. I co-chair our National Men's Health Committee, and probably the two best things I do is I coach football for a community football team that I'm extremely proud of, and I'm a father, which I'm extremely proud of a girl who is 2 going on 20, but we'll leave that for another day. And I say all of that to say this. At the end of the day, despite all of those accomplishments, everything that I do, despite wearing a coat, whether this coat was white, whether it was apricot, or whether it was a professional blazer, I'm still a Black man at the end of the day. And the reason that is important is because you may see me as a colleague, and one of the things that people do often is say, well, you're different, or I don't see race. And when you do that, you are discrediting somebody's struggle. You are discrediting their history. You are discrediting their trauma, which is automatically causing distress, right? And I say this because I'm also a patient. And I'll give you an example of what I mean by my accomplishments doesn't mean much when I'm still considered just a Black man in my society. In 2012, while doing house calls, I was in a car with my driver going to see a patient in the Bronx. And I was reading a book, A Dance with Dragons by George Martin. I'm a huge Game of Thrones fan. And I was reading the book because it was the latest book at the time. And my driver starts to pull over. And I told him, pull over by the fire hydrant, because often we park on fire hydrants. I get out, I see the patient, I come back because he's still in the car. My driver comes to a stop, a full stop, almost in the middle of the street. And then I hear somebody say, hey, what's that you're reading? In my window. I look up and it's a detective. And my driver puts his car in park, and the detective immediately goes, get out the car. And he gets out the car, right? So my driver is somebody who had a GED, wasn't well educated in the sense of policies and law, and was also quite frankly frightened by his past trauma with officers. I, on the other hand, had I grew up going through this, and then I was able to get the privilege of having my mother become a correctional officer while I was in college. I joined a fraternity, which means that I inherited fraternity brothers who were also police officers, sergeants, detectives. So I was able to have the knowledge of knowing I did not need to get out of the car. So at this point, the officer's like, you need to get out the car because your car smells like marijuana. And I'm like, that is impossible. I don't do drugs, and I'm also at work. And I get out the car at this point, and we get searched down, and the repeated question I get asked is, what are you doing in this neighborhood? This is what they're asking me. These are white detectives asking a black man in a black neighborhood, what are you doing in this neighborhood? And I'm like, I'm at work. I'm at work. I'm at work. My driver is sprawled over the hood of the car, meaning both his hands, palms down on the car, face into the car, getting all his pockets dug out of and all type of violations of his rights. And I ended up going back with the officers for about 15, 20 minutes. They threatened to put my prints on things. They threatened to take me in, all sorts of things. Now, this would be a tragic situation if this happened one time. Most tragedies usually happen about one time. This was just one of many times that this happened to me. As a black boy, as a high school student, adolescent, in college, I was pulled over because somebody told me it was 4 black men, and my cousin, whose wife now is a white woman, was in the car with us, and they pulled us over just to ask us if she was okay, right? As a nurse practitioner, I was pulled over several times. Like, that wasn't even the last story of me getting pulled over. I had other stories of me also reading books and being pulled over while in the front seat. And some people may ask, what does this necessarily have to do with nurse practitioners? This is not something that we can fix. But you have to understand that these are things that your patients go through, and then they come into your office, right? Or more importantly, these are things that your patients go through identifying systemic racism and also associates it with healthcare and do not come into your office. So it's important to understand that. When Dr. Fields and Dr. Crespo was talking about the historical significance of racism in healthcare, you need to understand how that is passed down from generation to generation, right? And some people like to say that, well, you know, if and true story, psychologists argued against blacks being freed because they would not be able to handle being freed due to the mindset of being enslaved. This was legitimate arguments that was happening, right? Going down to black women being experienced on in gynecological procedures, right? So you have all of these things, but then also you may think that this happened so long ago, but then also you get in 2016, there was an article published where 50% of white medical students and residents believe that black people had higher pain thresholds because they have thicker skin, right? You can't make this up. This is less than 5 years ago that this article was brought up. So the same way that things are passed down to us generation to generation as black people and as Latinx community, they're also passed down in white communities. So it's important to understand the systemic of it all, right? And it's important to understand that a system can have no racist in it, but if it's systemically racist, it will still produce racist consequences. So it's very important to understand that, because right now the main focus lens may be on police officers, but the next lens that is coming up is healthcare. Right now, there are plenty of memes that are circulating in black communities that say doctors and healthcare system are killing more black people than cops, but y'all aren't ready to talk about that yet, right? And if you don't know what they're talking about things like black women mortality rate being 4 times higher than their white counterparts, black women mortality rates being worse than some third world countries, right? And some of those things don't go according to your socioeconomic status, because black women who have college degrees have worse outcomes than white women who don't have high school diplomas. Black women who make high salaries, 6 figures, have worse mortality outcomes than white women who don't do that, right? So you have to understand that we are part of this system that is producing these negative consequences. And the more that we don't say anything about it, the more that it's happened, but then also the more that we're going to be labeled as those people as well. Dr. Fields talked about silence. And I heard something recently that said, silence is evil's greatest ally. Because often when we start talking about racism, what ends up happening is that it makes people uncomfortable. And when they become uncomfortable, they get quiet. That quiet that you give off because you don't know what to say, because you don't want to say the wrong thing, right? Or because you feel it doesn't apply to you, so you're letting it fly off the wall to whoever it goes to. It's the same exact silence that people who are racist give when they are called out on something, and they know that if they are quiet for long enough, that it will go back to being the way that it was. So you have to understand what silence is doing, right? And it's important that we understand that. Now, what can we do as nurse practitioners then, right? Once we start understanding that the system that we are doing was never meant to treat Black people, right? It was never meant to treat slaves. It was just meant to use slaves to treat other people, right? So we have to start reimagining our healthcare experience. Once we reimagine it, and during that process of being reimagining, that means bringing in your Black colleagues, bringing in your Latinx colleagues, bringing in the other people of color that are your colleagues, right? Starting patient focus groups to try to understand their experiences. This cannot be fixed with just reading off the slides that Dr. Fields, Dr. Crespo give, going through one implicit bias training, and then everything is going to be okay. That is not going to fix it, right? What has to happen is that we have to start reimagining it. And we have to understand when we're coming from a place of privilege, right? And there's different levels to privilege. I understand that as a man, I have more privilege than a woman does. I understand that as a Black man, I have more privilege than a Black woman does. But it still means I need to check my own privilege. A great example of this was I had to realize that I was on a board for a Black Nursing Association organization, and we did not have a committee dedicated to Black mortality for women, right? And I did not realize that until my sister was in a hospital giving birth to my nephew at 24 weeks, who came out 1 pound, right? I did not understand that until a week after that, one of my fraternity brothers lost his daughter to childbirth, to complications of postpartum hemorrhage. And then I had another fraternity brother lose his daughter before she was born. And then it clicked to me that my privilege prevented me from treating these problems, from even acknowledging or addressing it. But once it was brought up that my privilege was blinding me, it was, okay, now how do we reimagine it? And that just started out with saying, we're going to start a committee that addresses these issues. Do anybody want to be a part of it? And as they came and started signing up to be a part of it, then it started saying, who wants to talk about it? And those first couple of meetings, the women who treated with specialists and went through these things did not want to talk about it. And I had to do most of the talking of, so what do y'all want to do? So what ideas? Would this work? And some of my ideas was outrageous. Like Dr. Crespo said, you're not going to be perfect when you're trying, right? There has to be room to perfect this. But then what started happening was these incredible women started taking over. They knew exactly what they wanted. They knew exactly how they needed to be reimagined. And me and my privilege just needed to provide a platform for them, right? And then step out of the way and let them do what they do. And that is one of the most important things when you talk about reimagining and restructuring the healthcare system, right? And just like very quickly, there was a question about cultural competence, because I'm very big on, cultural congruent care. I'm very big on cultural competence, meaning understanding the culture of the patients that you are seeing. One of the things that made me so successful with treating my patients was understanding that I needed to listen to them and what they were going through. And also understanding that it's not a one size fit all. Often people try to say things like, well, can you give me a questionnaire that I can read off of and I can just get all of their social determinants of health, all of their problems, and it can make my life busy and make my life easier. Some patients will do that, you won't have a problem. Then there are other patients where you're going to have to constantly talk to them. You're going to have to build up that trust with them, right? And a lot of times I will go into patient homes and I always make sure I look them in the eyes, I shook their hands when I came in and when I came out. And some of those patients, that developed into, I had to start giving them hugs when I came in, when I came out. Because in some families, they don't give hugs. They don't give handshakes, right? We hug and we kiss on the cheek. And I had to understand that as I was treating those patients, that's the way that they wanted to be cared for. That's part of my care. Because what that turned into was a trust when I tell them, I need you to take your ACE inhibitor, right? Your ACE isn't working, I may need to try you on something else. I may need to add medication. It made them trust me in doing all of that, right? Because I can tell you one of the biggest reasons why a lot of your Black patients have uncontrolled hypertension, uncontrolled diabetes is, one, the mistrust in the system. And two, right, they don't tell you when they don't take their medication. And they just come back to see you with their blood pressure uncontrolled, and you give them another medication. When they finally get a headache from their blood pressure, they finally take all 2 or all 3 medications, their blood pressure drop, and then they say, that doctor don't know what they're doing, I can't trust them, let me put my medication to the side. I know that because my mother does it, my sister does it, my aunts do it, right? And I end up having to have conversations with them. And it often starts with, Mom, did you tell your doctor this? No, I don't trust him. Plus my doctor doesn't listen to me. He's trying to get me in and out, right? And I understand that we're playing the money game as providers and trying to produce more income. I understand that. So if that means that we need to get paid more per patient to be able to provide these services, then we need to rally our political system as nurses and nurse practitioners and demand that we get higher reimbursement for Medicaid patients, for Medicare patients, whatever that is, right? So it means that we have to attack it from different areas. And I don't want to keep you too long rambling and going on. So I am going to open it up because I know Dr. Ferreira wanted to get to some of the question and answer period.
Thank you, Dr. Johnson. Thank you, Dr. Crespo-Fierro. There are some questions. So there was a question about, it was to Michele. Can you give a few more examples of culturally congruent care?
So one of the first points is to understand more about the culture. So what are their expectations? What are the cultural practices? Are there perhaps herbal remedies that the community uses? And are there other practices that are done? Sometimes there are some spiritual practices. So I guess let me backtrack and give a little bit of my background. So I'm of Puerto Rican heritage. So I have family members and myself, we grew up with some practices that are called espiritismo. And there are ways in which we address problems spiritually first before we address them physically, right? So understanding those types of behaviors. So what would someone do then if you have a client that perhaps will go to their spiritual advisor or their reverend first before they come to you, and not just for a psychological issue. This could also be a physiological issue. So if you knew that about your patient and your client, you would ask them, and you could do this either during the initial intake or perhaps in other intakes, kind of following up in subsequent visits. What are the practices that they do? So if there is, this is someone who maybe has, I'll do something with diabetes. So we know this is someone who has high sugar, and there are certain things that they do when they're together at these practices or services, and they're foods that they are expected to eat. So then you would, working with them, because you don't want them, they're not going to give up that practice, right? They've told you that. You don't want them to give up that practice because it gives them comfort. It gives them community. So then you would work with that individual to perhaps alter what they're eating earlier in the day. So that way, when they eat this sweetened food, it's not going to have as great of an impact on their sugar levels for later on in the day. You would do this either if they were on insulin, you would do this if they were not, and perhaps you'd say, okay, you're going to engage in a little more physical activity earlier in that day to allow you to be able to have that sweetened food item and have it not shoot up your sugar as much as you would otherwise, and perhaps not eat anything else that's sweetened, just that one item that is expected of you. So that is one of the ones that would be more of a restructuring and a little bit of an accommodation as well. So depending on who your population is, who your patients are, what you know about them, what their health conditions are, you'd actually come up with a list of things that fall into the different categories. And of course, anything that they do that you would want to encourage, especially if you know that it's not going to have any impact on their health conditions, then absolutely encourage them to do that as much as possible. So that's one example, a quick example, but it takes a lot of work to get all the information together.
No, that was very, very good, Michele. In the fact that it does take so long, I think, or it can take so long, I think is really relevant, and it's not a time deal. It's ongoing.
Yes, exactly.
Thinking about the relationship that we have as advanced practice nurses with our patients. Johnson, there's a question here for you. How can minority faculty begin to address structural racism, particularly in our NP programs, when we're dealing with a system that has been so well established that did not see us as individuals capable of even reaching such levels?
So my response to that would be, the first action would be restructure the whole thing. And people have to understand that one of the main reasons I made the point of a system can have no racist in it, but if it's racist, still produce racist consequences, is because if the system was never intended to treat or be fair, it will continually to create disparities in one way or the other. So that means that we have to completely restructure it, right? And that means bringing in more faculty of color. Like I always often ask people, does your faculty reflect your patients? Do your faculty reflect your student population? Because that's one of the quickest ways to bind with people. People feel more comfortable with people who look like them, talk their language. That's just what it is, right? And if it doesn't, then you need to bring people in to begin that cultural competence, that cultural training, so that your faculty can understand what your students are going through. So if you're not willing to reimagine and restructure, in this day and age, you're going to end up getting left behind, right? Because that is where we are at now at a society. You hear people calling to defund the police. That doesn't mean that there's going to be no police. It means that they're going to take some money away from police and reinvest that into community resources. Because the safest communities in America are not the communities with the most police, it's the communities with the most resources. It's that same mindset within healthcare. The best institutions that give out the best cultural competent care, give out the most cultural competent education, are going to be those institutions that are well diverse, are well influenced by people of color to be at that decision-making table.
Thank you. There's a question here, an NP who's working in dialysis with a largely people of color population. What do you two think are the most helpful thing in increasing trust healthcare providers? Because she feels that a lot of the quote unquote non-compliance is actually mistrust.
And so I think that starts with taking your time and respecting the boundaries of your patients. You have to understand that it is not going to be a one system fits all for people. It's going to be individual for a lot of people, because some people have been passed down a mistrust. Some people have their individual experiences that created their mistrust. So it's being able to get down to the bottom of that and understanding that you're not going to get all of that out in one visit, right? Like you're not going to be able to completely understand why they mistrust the system at the same time as seeing them for the first time, balancing their medications for their hypertension and their diabetes, and also screening them from hyperlipidemia. We're not going to be able to do that in one visit. So understand that you have to continue tackling it with each visit. And then also understand that, for example, there'll be sometimes I'll go to a patient house, and normally what would take me 25 minutes would take me about 1 hour and 15 minutes. And that's because out of those hour and 15 minutes, an hour and 5 was spent talking to the patient, not examining them, not writing prescriptions, not dealing with another provider, was just considered talking to the patient and stuff that they were going on with their family. But what that does is that it built trust. So my other visits was very well back to that 20, 25 minutes of dealing with them, because they understood that they trusted me when I would tell them to do something. So you have to understand and be willing to go the extra mile for those patients, knowing that what you're doing, that 1 or 2 times, taking that extra time, is going to build trust and get you back to quicker patient visits later on.
And I'd like to just add, being the daughter of a former dialysis patient, is that, you know, it's a huge commitment, and particularly if it's related to diabetes. Oftentimes they've been in the system a long time, and there have been, you know, there have been many things that they have been told, and I use the word told because they were not asked. They may not have gotten the information where someone in the past took the time to find out who they were, what was important to them, and really come up with a plan to control their sugar. And then really also explain to them what it means and what potentially could happen to them. So, and then you have a cascade, because it's one thing after another after another. So they may have had some trust before, but they have been failed. They've been betrayed. They're being betrayed by their bodies. So you are, and you don't intend to be, but you're a reminder of all the things that are going wrong for them. And that time, which is a huge chunk of time, that they're away from their family, their friends, the other things that they need to do. So it is going to take time sitting with them, listening to them, getting to know them, and seeing that their time with you at that center could be a positive thing for them. But it's not going to happen. And again, this is not easy. We're not giving you an easy solution. It isn't an easy solution, and it does require lots of work and talking.
There's a really interesting question here, Michele, for you. This says, you mentioned we need to rethink informed consent versus re-traumatization. How can someone overcome their fear of racism without re-traumatization? Because I experience this often in my practice, but still don't know how I can escape re-traumatization. You're on mute. Come off mute.
Yes. So I think, so there will be some re-traumatization. It is impossible to avoid it. However, you want to minimize that as much as possible, and meaning that the amount of trauma and the repetitiveness of the trauma you want to minimize, but you also want to be ready with resources. If this is someone that's going to need resources outside of your practice, have those ready to go. But at the same time, also find what are resources for building resiliency that you can utilize with them in that moment as well. So I do highly recommend, there are wonderful resources regarding trauma-informed care and practices that you can incorporate into what you're doing, again, to minimize that traumatization and build the resilience that they need, because we can't protect everybody. That's not what we're talking about, is building the ability to rebound from that and rebound in a faster way.
Can I add to that, Dr. Fields?
Absolutely, go ahead.
So if I made this statement to everybody and said, healthcare providers are upset with the way patients talk about them and with the yelling that goes on and the throwing objects while they are in our clinics and our hospitals, so therefore we are no longer providing care. We are no longer, if you are bleeding or have an active problem, we will stop it and then that's it, right? Everybody would think that that is absurd, right? I would hope everybody who here is a nurse would think that is absurd, right? So we have to get comfortable with being uncomfortable, right? We have to, so when you're talking about trying to avoid re-traumatizing somebody, you have to understand that you may get yelled at, you may get cursed at, you may get told off, and it may have absolutely nothing to do with you, right? But you have to understand that that's part of the process of them healing and starting to trust you, right? You have to get past that anger. There's been a lot of times when I walk into my patient house, they curse me out, they tell me I don't look like a doctor, tell me I'm not dressed accordingly, whatever the case is. By the time I'm finished seeing them for that first time, they're asking me, when am I coming back? Please come back. And I start laughing. And then they also ask me, how come you don't get upset whenever we're upset or have an attitude? And I tell them, it doesn't matter what you think of me when I walk through the door. It only matters what you think of me when I walk out the room after I see you. So with that, you have to be uncomfortable with being uncomfortable. Let them express those things, right? Let them define what their trauma is to you, right? Let them decide that if it's traumatic and they don't want to talk about it, or let them just go off and understand that that's part of our job as being nurse practitioners. It is legitimately what separates us from other providers, right? Because we take care of people. We don't take care of diagnoses, right? So because of that, understand that we're taking care of people, we're getting to know their problems and what's causing them their stress.
So there's been some comments around, well, what do we do? Where do we move to from here? How do we develop an action plan as nurse practitioners to move forward? And I'll actually start answering this question from my sort of lens in health policy. Nurses do not own their power. Nurses do not own their power. Nurses do not own their power. That comes from educational pedagogy. You say it 3 times, you'll remember it. So I'll say it for a 4th time. Nurses do not own their power. We are the largest segment of the healthcare workforce. It is not our physician colleagues. It is us. If we exercise that power through a political agenda that puts forth the premises that Dr. Kamara Jones talks about, that I talked about earlier, about how we achieve health equity in this country, again, and I'm going to repeat them. Providing resources according to the need of people in those communities, which is how she refers to it, valuing all individuals and populations equally, because that is what we are taught to do as nurses, recognizing and rectifying historical injustices. But when is the last time you wrote your elected representatives about healthcare issues within the populations that you care for? The organizations that you belong to. When is the last time you attended their advocacy day? For those of you who may wonder what that is, I invite you all every February, the first week, Black History Month, the National Black Nurses Association has our annual advocacy day. We take an agenda to the hill. I chair the National Health Policy Committee. You are always all welcome to join us in our advocacy. We take it to them and we educate them. But I really want us to tap into how we use our power. There are 2 nurses in Congress, 2. Both of them are Black. The first one, Edie Bernice Johnson, was the first nurse ever elected to Congress. The second one is Representative Underwood, Lauren Underwood. So we have got to be very clear about what we are doing with our power. So I'll stop there because I can keep going and we got to end in about 5 minutes. So Dr. Johnson and Dr. Crespo-Fierro, action plan.
Well, since Dr. Fields put in a plug for the NBNA's Hill Day, I have to put in a plug for the National Hispanic Nurses Association of Hispanic Nurses. We also have a Hill Day. It happens to be the same day. We like February in DC in February, and we're actually going to be working on pulling our respective agendas together, because just imagine, you know, what we can do with our Black and brown faces together on the Hill, and I am looking forward to that. Action plans. Yeah, absolutely. You've got to get involved. We have to not be comfortable. We've talked about uncomfortable things. It's an uncomfortable situation for our patients, for ourselves. I've been looking in this chat, and you know, sometimes we're tasked with taking things on and speaking up, but we do have to speak up. We have to continue to speak up. We have to make sure that we have our self-care to support us after we speak up, but we have to continue to put ourselves out there. We could do a better job of being organized and pulling our resources, but you know, that's what we need to do. We need to put ourselves out there.
So I would say we have to, on top of, I echo everything that Dr. Fields and Dr. Crespo-Fierro said. And I think that when we are reimagining and restructuring these systems in healthcare institutions, we have to thread this throughout everything. You cannot have one-off solutions, right? Everybody likes the quick fixes. An implicit bias training that you attend one time is not going to fix an entire system, right? This has to be threaded throughout the entire reimagining and restructuring, and then individualized to the different patients you see, different clinics, different units, different institutions of higher education. It has to be threaded throughout and individualized to fit the needs of those specific populations. And then I will also just leave you with this, and this is something I always think about. Nursing is the sleeping giant, and it's asleep because of fear. And when nurses finally awaken, healthcare and the world itself will change.
Thank you both. The last plug I'll put in, and I'll turn it back over to Stephen. All of us has a responsibility to the next generation. If you are not actively serving as a mentee to someone who is trying to strive to be that which you are not keeping true to everything that we should be doing as nursing professionals with advanced degrees. There are not enough Black, Latin NPs. There are not enough nurses. We need to increase those numbers, and we need your help to serve as mentors. On that note, thank you all. I'll turn it back over to Stephen to close us out.
Thank you, Dr. Fields, Dr. Johnson, and Dr. Crespo-Fierro. This was a fantastic session. I'm sure we could have gone for another couple of hours with the amount of work we need to do. What was important for me and the Nurse Practitioner Association was this is the start of a conversation, one that, in all honesty, should have been happening a long time ago. But we are not ending with just this one webinar. There'll be a continuation of information coming. We're going to work together with the National Black Nurses Association, the National Association of Hispanic Nurses. We need to work together. We have a big year next year in New York State for nurse practitioners with the sunsetting of the Nurse Practitioner Modernization Act. This is access to care for our patients in our communities. If we need to have an arbitrary barrier in order to practice, it is going to really bottleneck our healthcare system in New York State. We need the voice of all nurse practitioners in New York State so that we can overcome, we can fight to the top of our practice, to the top of our licenses, so we can take care of the patients that are in our communities. With that, again, thank you everyone. This is being recorded. We will get a link up. We will send a link to the slides to everybody who registered tomorrow, and have a great night. Thank you again.